think one of the issues in the adjuvant space, though, that always comes up is toxicity, and the balance between toxicity and an efficacy that you can't measure in real time in the adjuvant setting really becomes a key conundrum in the clinic. Arlene, I know you have probably the more experience than anyone managing toxicity to erdafitinib. What recommendations do you have for clinicians using this for the first time?
Well, when we look at the toxicity, it really does, there seem to be early effects and then the cumulative effects, like you see with other TKIs, including the hand-foot syndrome. As far as the early effects, we do see hyperphosphatemia, but we actually increase the dose, pushing to a level of hyperphosphatemia because there was an early sense that this might contribute to the response or benefit from treatment. And that's why erdafitinib has this up-titration schema where it used a phosphorus level of 5.5 on day 15, and if it was less than that, you went up from 8 milligrams to 9 milligram dosing. Now, despite this up-titration, we don't see long-term phosphorus toxicity. And it's thought because there's homeostatic mechanisms that occur using continuous dosing that then allows the kidney to excrete more phosphorus. So we haven't needed to use, at least in my experience, I haven't needed to use as much of the phosphate binding agents like sevelamer. Whereas other trials have utilized more. And perhaps it's a difference in schedule. When you give it intermittently, the homeostatic mechanisms allowing phosphorus excretion may not necessarily occur or occur to the same degree, perhaps. But we do see these long-term effects. We do see in patients who are receiving treatment, they get a hand-foot syndrome, peeling of the skin, paronychias, and that's been one of the most frequent causes of holding the drug, at least in my patients. And the patient that I still have on treatment today, more than 3 years on therapy, about every 3 months, he requires a 2 to 3 week off period to allow hand healing to occur. And this is despite doing a lot of, preventive maintenance to the hands. I tell them baby your hands, use hand creams, especially the emollient creams. Living in Texas, several of my patients found that when they were waterproofing their boots with mink oil that you can buy in a sports store, that was working very well on their hands. And so they buy a $6 tin of mink oil. Mink oil, if you buy it as a beauty product for women, it can be $100 an ounce. So much cheaper when you buy it to condition your cowboy boots or baseball gloves. But the mink actually has, when I looked up the properties of mink oil, it says it most closely approximates human sebum. So it might be closer to humans. And then mink also, they're water animals, so perhaps some water protective effects in addition to, the water protection for leather. So I had several patients using the mink oil that they use on their cowboy boots, which actually seemed to help very well.
I love that story. Straight from Texas.
Now, of course, the one that everyone worries about is the whole central serous retinopathy. And we'll hear more about that from our esteemed ophthalmologist who will be able to tell us more about that process. And when we look at central serous retinopathy, it's felt to be a potential class effect through inhibitors of the MAP kinase pathway. It's been observed with other inhibitors of MAP kinase as well. And we did monitor for it in these patients by doing baseline ophthalmology scans and ophthalmology visits. And then we did Amsler grid testing, looking for wavy lines, because anything that might disrupt your retina would cause a bit of visual changes or blurred vision. And then if a patient ever reported a wavy line or blurred vision or change in vision, we immediately held therapy and sent them to ophthalmology to make a diagnosis. There were, I believe, only 3 patients who actually discontinued for central serous retinopathy. And in the patients I had who developed it, I was able to resume treatment in most of them. The one patient we didn't, it was a patient choice. He went on to alternate therapy and was having difficulty coming back and forth to Houston. So it was reversible. It did appear tolerable. It didn't result in any long-term vision damage. Now, of course, when we treat thousands of patients, we'll have to see how that bears out. And that's why there's such close monitoring recommended currently by the FDA for FGF-targeted therapy. So I would say it would be good to have your ophthalmologist added to your Christmas basket list because you'll probably be communicating with him before starting patients on treatment with erdafitinib.
Great. Good tips.